Hey everyone, welcome back to another episode of the Rick and Danny Show. Danny, how are you doing this afternoon?
Doing really well, Rick. Excited to be here. We're going to highlight a few things from the most recent annual conference up in Chicago, the ASCO conference.
Yeah, and if you listen to, depending on when this airs, our last episode, we did mention it as well, sort of the big Medical Oncology Society meeting each year where a lot of usually practice-changing or potentially practice-changing research is presented. Do you want to talk about your study first, or do you want me to go first?
I'll highlight mine first. It's
Classic,
coming out
jumping the line, Danny Kabrinsky, second fiddle here. Okay, all right, no, I see.
Sorry, Rick. Sorry.
No, go ahead, Dr. Kabrinsky.
I'm just so excited about mine. So this is a trial that was reported. It's a phase 3 trial in patients with small cell lung cancer. So I love seeing that we're getting some positive data for small cell lung cancer. I think a lot of trials have been negative over the years in terms of having a new agent that's, a new target that has clinical benefit in patients with small cell lung cancer. We're using, still in daily practice, in a patient with small cell lung cancer, we're using chemotherapy that has been out, more than 20 years. And that's the standard approach with the addition of immunotherapy. But this is a new agent that I'm going to talk about, and it was studied in a phase 3 trial called the Delphi 304 trial. And they were investigating a new bispecific antibody. We've talked about bispecific antibodies before, Rick. And these are engineered antibodies targeting two different things. So usually it's a target on the cancer cells, a protein that's being expressed for binding. And then the other target is the T cells. So a receptor on the T cells that leads to activation of patients' own immune cells. So what they're trying to do with any bispecific trial is infuse a drug that binds to the cancer cells and then at the same time activates the patient's immune system to fight the cancer. And so this particular agent called tarlatamab is a bispecific antibody targeting a protein called DLL3 that's delta-like ligand 3. And by binding to that protein, what they're trying to do is inhibit neuroendocrine differentiation or basically stop the neuroendocrine cancer in its tracks, because small cell lung cancer is a neuroendocrine cancer. It's a very high-grade, aggressive, quick-growing lung cancer. It accounts for about 15% of lung cancers which are diagnosed. And the Delphi 304 trial was comparing tarlatamab to standard chemotherapy in the second-line setting in patients with extensive stage small cell lung cancer. So extensive stage small cell lung cancer is the same as us saying it's metastasized. We treat extensive stage small cell lung cancer usually with chemo and immunotherapy in the frontline setting. That's in the first line. And then if patients recur, and I'll say when they recur, because most patients do recur, in the second line setting, we normally give chemotherapy. And there's a few different options of chemotherapy. There's lupronectinin, which is a newer chemotherapy that came out not too long ago. There's actually a variety of other second-line chemotherapies. I'm not going to go into every detail, but this was this new tarlatamab bispecific antibody compared to standard chemotherapy in the second-line setting in extensive stage small cell lung cancer. So let's get to the results. What they found is those patients who were treated with tarlatamab demonstrated a significantly longer overall survival compared to those given chemotherapy. There was a 40% reduction in risk of death in the tarlatamab group, so those receiving the bispecific antibody. Median overall survival was 13.6 months compared to 8.3 months in the chemotherapy arm. And the survival benefit appeared to extend across all the subgroups, no matter the age, the gender, the race, or the prior treatment. It didn't matter, that the benefit seemed to be consistent over all those subgroups. What can you expect toxicity-wise from this agent? Bispecific antibodies can lead to a toxicity, usually during the first treatment, called cytokine release syndrome. That's when your immune cells activate and bind and kind of try to eliminate cancer cells. There's a lot of cytokine release, which leads to more immune cells infiltrating into the site of the tumor, and you can experience an illness called cytokine release syndrome, where you can develop fevers, low blood pressure, fatigue, sometimes confusion. Sometimes, if it's severe, patients need to be hospitalized. So at CSNF, we do offer this treatment, and we always do it under a monitored setting. Dr. Ayed kind of heads our bispecific antibody program over at our Riverside location, and he gets patients started on these bispecific agents, including this new one that with all this positive data coming out of ASCO, and make sure that that first cycle goes well, monitoring the patient. If the patient needs to be hospitalized, we do that. We make sure that the first cycle goes smoothly, and then once the patient's on to their second cycle,
I think I'm on.
we're usually
Sorry, Danny.
continuing that treatment at the patient's home base. So if they're treated by me, they'll come back to the Beaches Clinic. If they're treated by Rick, which now they won't be with Dr. Cassie, but they'll be with some of his colleagues at the South Point location or the Fleming Island location, they'll come back to that center for their second cycle onward. So I think it's very exciting data. I think a few of us have already started patients on this new treatment. So we're excited that we have a new treatment that's very effective, that showed a benefit, overall survival benefit in patients with small cell lung cancer. What do you think, Rick?
Thanks for highlighting that study. I mean, I think bispecifics clearly seems to be one of the new avenues, along with theranostics, as sort of a next gen systemic therapies.
I agree. Next gen is the right point there, Rick. And I'll highlight one more thing coming out of ASCO, which caught my eye. Another bispecific, or shall I say, trispecific therapy.
Oh, God. Oh, no.
So trispecifics are actually binding to two different proteins on the cancer cells. And there was a study in myeloma patients, four lines of therapy. So multiple myeloma, this is a blood cancer that we treat every day in our clinics. Patients who had 4 lines of prior therapy, so heavily pretreated population, were given a trispecific therapy binding to two different proteins, activating those immune cells. What do you think the response rate was for this trispecific agent in heavily pretreated multiple myeloma?
Response rate meaning any response?
Yeah, overall response.
50-50?
100%.
Oh, snap.
Yep, that's why I brought it up. Next gen, this is game changing. Now, this was a phase 1/2 trial, so early trial. I don't think any comparator arm. So
hypothesis generating.
Yes, it has to be developed more, has to be compared to standard of care treatments. But whenever you see an overall response rate of 100%, it catches your eye, right?
Absolutely. Yeah, no, I mean, sort of like the rectal trial with immunotherapy and mismatch repair patients.
Yes, right.
It's hard to
All
argue
patients
with that.
Responded, right?
Right.
Yep.
No, I think that's a really good summary of bispecifics and apparently trispecifics. You taught me something today, so I appreciate that.
No
Teaching
problem.
me every day, Danny.
Oh, thanks.
My study is the one I wanted to talk about that came out, is a phase 3 trial comparing basically the addition of cemiplimab, which is a immunotherapy drug that Dr. Kabrinsky is very familiar with and gives on a somewhat routine basis. But this study looked at high-risk skin cancers. So we know that skin cancers are the most common cancers in both men and women, non-melanomatous skin cancers, specifically a subset of those being squamous cell. Now, the vast majority of squamous cell cancers you can treat with surgery or radiation and be done and have very high success rates. But occasionally, these skin cancers can have very aggressive features. So what this study looked at was basically patients who had extremely aggressive skin cancers, and I'll go through the specifics, but they all received surgery They all received radiation after surgery, and then the trial was randomized to compare cemiplimab in half the patients versus the other half of the patients getting observation or placebo. And so what they wanted to see was, could there be an improved response rate for these high-risk skin cancers when you add immunotherapy after surgery and after radiation? So the study criteria for what do they determine as a high-risk skin cancer is basically any disease with nodal disease where the largest node was greater than 2 centimeters and had extranodal extension, or if the patient had 3 or more positive lymph nodes, or they had in transit nodal metastasis, like dermal metastasis. If they were T4, which for skin cancer typically means invading the bone or other cortical structures, so super deep invasion, perineural invasion of a named nerve, so not just small perineural invasion, but large nerve invasion, or if it was a recurrent skin cancer from a previously treated area that had any high risk feature, so deep depth, perineural invasion, poor differentiation. So we all know these recurrent ones tend to be a little more aggressive. So in the study of those patients, what they found was that basically adding the cemiplimab showed a meaningful reduction in disease recurrence. The overall survival data is still maturing, and at least as they reported it, there was no difference at the time of this publication. But certainly there was a significant disease-free survival benefit, 2 years survivable SDFS benefit of 87% in the cemiplimab arm versus the 64% in the placebo arm. So a pretty solid benefit. And then, the expected toxicities associated with most immunotherapies that, grade 3 or more adverse events related to sort of all treatments was 24% in the cemiplimab arm versus 14% in the non-immunotherapy arm in the placebo arm. But again, that's all treatment-related toxicity, so it's not just toxicities related to the immunotherapy. And then in the combo arm of all three, about 10% of the patients had to stop treatment from the immunotherapy due to treatment-related toxicity versus 1.5% in the placebo arm. So I would say those numbers tend to fall in line with other immunotherapy studies. Danny, I don't know if you agree with that in terms of the side effects.
Yeah, I think that's expected based on other studies. I don't remember exact percentages off the top of my head, but certainly expected toxicities.
So yeah, I think this is a good option. I've got 1 or 2 patients now that are in the queue that I think are going to probably go along this kind of more high risk path of they've had surgery, they're seeing me for radiation, and then they're going to see one of my medical oncology partners to discuss cemiplimab. Everyone.
Sounds good. I think, has there, and I can't think off the top of my head, this was all squamous cell, Rick, or?
Correct.
Yeah. And as far as radiation being standard in those patients with high risk disease, how much do you think the benefit, the question is how much immunotherapy benefit is there without radiation versus, with radiation given before the immunotherapy?
I think it's definitely, I can't imagine with radiation, you're talking local control rates,
right,
well above 90-95%. So I think it's more for preventing the nodal metastasis. The distant metastasis would be my gestalt of where the benefit lies. I think, let me see if they have those numbers. Everyone. They don't have it broken out in the abstract, but I do have the article somewhere. Everyone. Brandon, you can cut this part out.
They gave treatment for about a year.
Yeah, they gave it for
6 months. It's either 6 or 12 months normally. Probably a year.
It started at the frequency of every 3 weeks, then it was switched to every 6 weeks, and So they gave 350 milligrams IV every 3 weeks for 12 weeks, followed by 700 milligrams every 6 weeks for an additional 36 weeks.
Okay.
So that would be 36 plus, so 48 weeks, so almost a year of treatment. And then your question about the recurrence number. Everyone.
Yeah, more of these trials, even like the Keytruda data in cervical cancer, are spacing those treatment intervals out to 6-week intervals just for convenience sake.
So you just double the dose and then give it every 6 weeks?
Correct, yeah.
Everyone.
I actually have not been doing that for most of my patients, but I kind of prescribe to the higher dose, more toxicity. I think there's some data to suggest that for immunotherapy, but it's up to the patient. If the patient doesn't want to come in every 3 weeks, then I don't force them to.
So they're reporting in here that they broke it out by distant versus local regional recurrences, and there was a benefit actually in both for the cemiplimab.
Oh, interesting. Yeah.
Now I wonder, how you define regional as, in the eye of the beholder. So I wonder how many of it is nodal recurrences versus true skin recurrence. Would be interesting, but that doesn't appear to be broken down.
Yeah.
But no, I think overall, I mean, for me, if a patient meets this clinical risk criteria, which thankfully, again, when you look at skin cancer across the spectrum, this is a small minority of patients that have these aggressive features, but certainly it's a good tool in the toolbox. Everyone.
Yeah, I think ultimate question that I have, and I can't say that I treat skin cancer all that often. I mean, we all have a number of patients with squamous cells and use immunotherapy in that setting, but it's different than an academic center that only treats, squamous cell carcinoma in their practice. But is the neoadjuvant, cemiplimab, is that actually something that, again, for the high risk individuals, is that something that's going to be more practice changing in terms of offering neoadjuvant to everyone? Because there is some data for neoadjuvant,
I think it's phase 2 data. They certainly have given it in patients as well, and it's also decent data for patients who can't get surgery or can't get radiation for whatever reason.
Right.
But no, I think that's definitely, a reasonable path if you have a very aggressive skin cancer that you know of up front to see. And then the real question is, if you're in that minority that get a complete response, do you still have to do the morbid surgery or not?
Yeah, or the surgery itself.
Because you can scan them and see the clinical response. I think that's the unanswered questions but no, I agree. I think a neoadjuvant approach is also, would be reasonable to consider for these patients if you knew they were likely to have very high risk features up front.
For everyone listening, neoadjuvant means preoperative, before surgery. So, and the reason we bring that up is because, or before radiation, and the data, for neoadjuvant immunotherapy with chemo in lung cancer, breast cancer, it's really positive data. Actually, has shown an overall survival benefit. So I would imagine that it's going to hold true for a lot of cancer types, that the sooner we give it, the better. And I do think that's why that we mentioned that rectal cancer study with individuals with Lynch syndrome, where 16 out of 16 patients had, response to therapy or complete response. The sooner we give immunotherapy, the better, I think.
Well, I think it just depends on the situation. Like if you're in a situation like the rectal cancer or certain skin cancers where the definitive treatment can be very morbid or disfiguring or carry with it a significant quality of life detriment, I think then neoadjuvant therapy to me makes all the sense in the world. Sometimes when we do it for situations where the patient may not have even needed the therapy afterwards, if an appropriate upfront surgery or radiation or whatever the situation may be, those would be the ones I would say you may favor against it. But I think overall, in general, you're 100% right that everything, like in breast, like in everything else, is moving towards a neoadjuvant approach. I mean, it's clear that when your immune system is at its most optimal, which would theoretically be before any surgery or radiation, it seems to be that these drugs work better, like we've talked about on previous episodes as well. Everyone,
Agreed.
Thanks to you all for tuning in. Hopefully you enjoyed learning about some of the slightly more up-to-date research coming out in the oncology space.
Thanks everyone for joining. We'll see you next time.
Take care.